We are live now. Please mute yourself.
Meeting call to order.
Thank you. I request President Rotarian PHF Ritika Gupta to confirm the minutes of the previous meeting.
The minutes of the previous meeting were circulated on the group and no queries have been raised on the same. Thereby, the minutes of the previous meeting are confirmed.
Thank you so much, President. Good evening, everybody. Today, we have an important topic on eyes, that is cornea transplant surgery, and by no other than himself, Dr. Quresh Maskati. He is the distinguished ophthalmologist of Mumbai. I request Rotarian Dipan Shah to please give the introduction of our guest today. Please unmute Dr. Rotarian Dipan Shah and give the introduction, please.
Hello. Good morning and good evening, India. Hello, Rotarians and guests. My name is Dipan Shah, residing in New Jersey, USA. I have the pleasure to introduce our guest, today's guest speaker, Dr. Quresh B. Qureshi. Eye health is something that affects every one of us, our family, and our community. And understanding how to protect our vision is incredibly important. So our today's wonderful guest speaker, Dr. Quresh B. Qureshi, is a distinguished ophthalmologist with career spanning over 4 decades. He has super specialized in disease of cornea and microsurgery, gaining advanced training in New York and Boston. Throughout his illustrious career, Dr. Maskati has held several prestigious positions, including being the youngest president of Maharashtra Ophthalmological Society and Bombay Ophthalmological Association. He further served as the president of the All India Ophthalmological Society and Cornea Society of India. Dr. Maskati's expertise has transcended borders, making him sought after guest speaker and visiting faculty in numerous international conferences. His global outreach has seen him deliver lectures in over 20 countries across all continents, including USA, South America, Europe, Africa, Asia. He is the only ophthalmologist in Asia to have performed the complex two-stage Pintucci keratoprosthesis, restoring sight to the totally blind patient, and the only eye surgeon in the world with expertise in the both Pintucci and Boston keratoprosthesis artificial cornea surgery. He has demonstrated live surgery of keratoprosthesis in over half a dozen countries. His pioneering work in the field of earned him several accolades, including Lifetime Achievement Award from the International Society of Cornea and Keratorefractive Surgery and the Maharashtra Ophthalmological Society. He has also been awarded a gold medal by the Indian Intraocular Implant Society. Dr. Maskati has been performed refractive surgery since over 25 years, including PRK, LASIK, SMILE, Contura, and Femto LASIK laser surgery. Wonderful, Dr. Qureshi, welcome. Thank you.
Thank you.
Which way I have to go? Thank you, Mr. Dipan Shah. Over to you, Dr. Quresh Maskati.
Am I co-host? Can I share my screen?
Yes, please.
Yes, please, you can.
One minute, and I'll just... This is just a glimpse going backwards. Okay. All good?
Yes.
All good.
Okay, so today we're talking about corneal transplant surgeries, but the whole concept of the corneal transplant surgeries is intricately linked with eye donation. If there are no eye donations, there can be no corneal transplants. So it fits in very well with your Rotary Club's theme of organ and tissue donation. Let us first see that we are all on the same page. So we know that the cornea is the front portion of the eye. If you see the picture, the black and white picture at the bottom, this front portion, just like the glass in front of your watch, that's called the cornea. It is clear, it is transparent, and it is got a finite thickness. It is dome shaped. Unlike our watch glass, which is flat, the cornea is shaped like a dome, like a little mountain, but smooth. And it is made up of several layers. It is important because when I talk about corneal surgeries, the concept of layers is important. So it is made up of 5 layers. The front portion is called the epithelium. It's about 5 layers thick, 5 cells thick. Then there is a membrane on which the epithelium sits. That's called the Bowman's membrane. Then 90% of the cornea is the middle portion, which is called the stroma. That is like your vada in the vada pav. And the inner lining is called the decimates membrane. And the innermost lining, which is a single line of cells, is called the endothelium. This is important to remember. So just when I talk about the cornea, remember that it's the front portion of the eye. It is dome shaped and it is made up of different layers, starting from the front, the pointing to the sky, that's the epithelium, then the Bowman's, the stroma, the decimes, and the endothelium. So what is different about corneal transplant surgery? First is it's amongst the early transplants which was done almost 120 years ago. The first corneal transplant in a human being was done in 1904. So almost 121 years ago. The beauty of a corneal transplant is that cornea has no blood supply. Unlike the rest of the body, all the organs that we transplant, the kidney, the liver, the pancreas, intestine, all the organs that we transplant are very rich in blood supply. So what happens is that when you transplant a liver or a kidney in a person, the blood vessels are all attached to the liver, the kidney, and supply blood and nutrition there. The body sends white blood cells which recognize that this is an enemy tissue. It has come from outside my body. Let me attack it. So the body tries to reject a liver or a kidney transplant. To prevent the rejection, the patient for his lifetime has to take either steroids or he has to take some immunosuppressive drugs, which can lead to infection. So the person is all the time on medication. But the cornea has no blood supply. So the body doesn't even know that I've done a corneal transplant. So it doesn't come to attack. So the chances of rejection are the least. Therefore, it's the most successful transplant in the whole body after hair transplant. So hair again has no blood supply. So hair transplant is the most successful transplant, but less expensive than hair transplant and almost equally successful is the corneal transplant. The third beauty of corneal transplant, it doesn't need blood matching or tissue matching. When you transplant a kidney, you have to see whether the tissue matching is there, the HLA factors are matching or not. Blood matching, blood group matching. So none of this is required for cornea. So any cornea from any donor can be transplanted into any recipient, whether you're related, not related, you're a male transplanting into female, you're a young man transplanting into old man transplanting into young man. Everything is possible. Any cornea into any recipient, any donor into any recipient. The fourth thing is, if rejection of the corneal transplant occurs, it can be successfully treated with just local eye drops. You don't need expensive and toxic immunosuppressive drugs. So any rejection, only a 20% gets rejected, 80% are successful. But if it gets rejected, it can be the rejection can be prevented or reversed by just typical topical steroid drops. And the fifth thing is that there is, I was, as my biodata showed you, I do a lot of artificial cornea surgery, but even for artificial cornea, we need the human donor because artificial cornea is made of plastic. How do I fix it in the eye? So I need a human donor in which I make an opening. I'll show you on the video. You make an opening in that and stitch the human cornea to the patient's own eye. And in the middle of that, I put that plastic cylinder. So even for artificial cornea, I need a human cornea. So these are just some fascinating things about corneal transplant surgery, which I thought I will share with you. But as I said, I can't do this unless we are all clear about eye donation and eye bank. So let me dispel quickly a few myths and facts about eye donation. So is there a need for eye donation? Yes. In India, 250,000 patients wait for corneal transplant surgery. Many of them are children and young adults. Total number of eyeballs collected per year from the whole country is only about 50,000. So only about 25,000 people are donating because each person donates 2 eyes. So this is peanuts considering that in Mumbai, the city where I am, almost 100,000 people die officially every year. Means the BMC, Bombay Municipal Corporation, records 100,000 people dying. There may be a 10% or 15% more who die and which are not recorded by the BMC as well. So the message is we don't bury eyes. It's better to donate them. So as far as corneal transplant surgeries is concerned, is the whole eye used for transplant? No. Only the thin transparent layer which is in front, as I showed you in that picture, like the glass in front of the watch, the brown portion of our eye, which is blue or green in the white skin races, and it is brown or black in our country. That's called the iris. That is inside. It's like the machinery of the watch. So in front of that is the transparent dome, which is the cornea. So if the cornea is opaque, if the cornea is damaged, like you see in the picture, the front portion is damaged, I can change it and give you a transparent cornea. That's to replace the diseased or opaque cornea in the eye of the recipient. So only if that front portion, the cornea is damaged, it can be changed. So what is new in corneal transplants? Previously, the whole cornea used to be transplanted. If you see the first picture of the whole eyeball that you see, the cornea in the center was dissected out. The entire thickness of the cornea was removed. This is the diseased cornea, and a transparent cornea was put in its place. We needed to take about 20 to 30 stitches to suture this. So this is called a full thickness corneal transplant. Full thickness because the whole thickness of the cornea, I told you all the layers. So right, the entire thickness from the epithelium to the endothelium and the stroma, the whole thing was transplanted. That's called a PK or a penetrating keratoplasty. Mean the penetration, whole cornea was penetrated. It's called a PK or a penetrating keratoplasty or a full thickness corneal transplant. So one cornea could be used for one patient. But now what we are finding is that why should we transplant the whole thing? Suppose only the front portion of the cornea is damaged. Then I dissect out the front portion from the donor and only transplant that. That is called a lamellar corneal transplant. So as you can see in this picture over here, lamellar transplant, the front portion was damaged. So I have transplanted only the front portion. In somebody else, the back portion may be damaged. So I'll transplant only the back portion. So the front portion is called anterior. The back portion is called posterior. So I can do only anterior or only posterior. So I can split the donor cornea into anterior and posterior and use it for 2 recipients. So one eyeball can be used for restoring sight to 2 blind patients. So a person who donates eyes can be used to restore sight to 4 blind patients, which is a revolutionary new thing in the last 10-15 years. So we are doing a lot of what we call lamellar transplants. Only the damaged portion of the cornea is transplanted. So this is again to show you, these are the technical names. You are not eye surgeons. I'm just, so you need not remember the end, but the front portion, which is called anterior lamellar, the technical name for it is DALK, which is deep anterior lamellar keratoplasty. You need not remember this, but in conditions like a conical cornea, where the cornea is conical, not nicely dome shaped, but almost like a triangle, we remove only the front portion because the inner lining is very good. So we do a DALK, which though we use about 25 to 30 sutures, because rejection is usually of the inner lining and we are not changing inner lining, success rate of DALK is almost 95%. And I told you the back portion, if it is transplanted, either only the endothelium and with the decimase membrane is transplanted, a surgery called DMEC, or the endothelium and the decimase membrane and a thin portion of the back portion of the stroma is transplanted, a surgery called DSEC. Again, you need not remember all this, but just to show you that we can only transplant the inner lining. And again, the chances of rejection become much less when you don't transplant the whole cornea. When you're doing the inner lining, we need only 2 or 3 stitches as opposed to 25 to 30 stitches for a full thickness or for a DALK. So I've talked about corneal transplant. I've said you can either do a PK or a full thickness, or you can do lamellar front or back. So corneal transplants don't guarantee sight to all blind people. Only transplants can only help. Again, I'm repeating because I get this question again, that my sister has got glaucoma and the sight has gone because of glaucoma, or my brother has got a retinal detachment. Will the eye transplant help? There is no eye transplant. It is only the corneal transplant. So if you see in this picture here, this is the nerve of the eye. The pink structure is the retina. So this is a picture of the back of the eye. So the nerve of the eye is damaged. It is usually pink. This is yellowish white. So this is called optic atrophy, where the nerve is damaged, like in glaucoma or in injury. So in such a case, if the cornea is clear, doing a corneal transplant will not help. In this middle picture that you see, where the cornea is damaged, you can see in the middle picture here, the white portion is the cornea, which should be clear, is opaque. This will be beautifully helped with the corneal transplant, almost 80 to 90% chance of success. Like in this young girl, the cornea in one eye is clear and the cornea in the other eye is opaque or white. It can be helped. So in the first 2 pictures, corneal transplant will work. In the third picture, this patient is irreversibly blind. We can't change the nerve of the eye. So we have to tell them, we are sorry, but the eye donation will not help you. What about rejection? Does the human body reject the transplanted donor's cornea? Human cornea, as I told you, does not have blood supply. So the risk of rejection is very low. Rejection can be suppressed by timely topical medicine, as I said. And in general, the chances of success are greater than 80%. This is a patient which I had operated about 2 years after the surgery. You can see this white mark around, that is where the stitches were. And the cornea is totally clear, transparent. You can see through inside. This white thing in the middle is just the artifact, is just the reflection from the fan. But see this picture, 20 years after the surgery. This is a patient I had operated 20 years ago when technology was not so good. It is a full thickness corneal transplant. Stitches were much thicker. They're now much finer. And you cannot even make out that this patient has had a corneal transplant. This cornea looks so normal. So chances of success are very, very great. What about corneas which are for some reason are unfit for transplant? Should we be donating them? Yes. Even if the cornea cannot be used for transplant, such as a patient who has HIV/AIDS. If a donor has HIV/AIDS, there are some WHO guidelines. I'll talk about them later. But I can use them to teach my students how to stitch corneas. So they are useful for research and for training purposes. So every cornea can be used. So how is the donation used? After the eyes are removed from the donor, they are evaluated, processed and screened, and then supplied to the eye surgeon for transplant. So they go to the eye bank. So this is rotary eye bank. This is not how corneas are stored. This is just a cartoon. They are not put in Godrej cupboards like this and stuffed in like your clothes. But this is the inside of an eye bank. It's a very sterile area. The cornea is carefully cut from the whole eyeball can be taken by the technician from the eye donor. But out of that, the cornea and a little portion of the white of the eye called sclera is cut away in the eye bank by an expert technician and put in a bottle which contains special liquid called MK medium. In that, the cornea can be preserved for 5 to 7 days. And if the patient is coming from far away, we can even preserve in a little more expensive medium for even up to 15 days. And then it is transported in an ice box with dry ice, which it can maintain the temperature at 0 degrees for 24 hours. So it can be it can be sent from the eye bank to the hospital where it's to be used. How quickly should the eyes be removed after death? As soon as possible. Eyes can be removed up to 6 hours after death, but in places where the climate is hot, like in most parts of India, preferably 2 to 4 hours after death is advisable. So don't waste time after death. It's not necessary to transport the donor to the hospital. Eye banks have persons who will come to the donor's house, whether it is a mansion, palace, or a jaggi jhopdi. They will come to the place of death and remove the eyes. They will come by their own transport. You don't have to arrange an Uber for them. So who can donate eyes after death? Anybody of any age, infants to old woman of 100 years, anybody having a spectacle power, high minus, high plus, doesn't matter. Any operated patient, even if the patient has had a cataract surgery, glaucoma surgery, retina surgery, even they can donate. As long as the cornea is clear, the donor will be useful. Whether whatever medical disease, heart problem, diabetes, high blood pressure, any cause of death, vehicular accident, stroke, suicide, heart attack, even cancer, as long as the eye is not affected by the cancer, it can be done. So then if everyone can donate, there must be some people who cannot donate. So who cannot donate? There is a WHO guidelines which says that those with neurological disorders, rabies, septicemia, patients with HIV, AIDS, those with blood-borne cancers cannot donate. Most important is those whose relatives are doing jagda afterwards and refuse donation. This is the problem that we face, that you go to collect, but one relative says deo and three other fellows say not to give. So then we can't do anything, because after death the body belongs to relatives. Even if you have pledged your eyes before death, if the relatives say no, you cannot. We cannot collect. What about religions? Any religion forbidding eye donation? Not forbidden in any holy books. It was not practiced. Luckily, when they were written, all the holy books have been written many, many thousands of years ago, and that time there was no eye transplant, so nobody has written anything against it. Certain religious leaders, such as Buddhist monks in Sri Lanka and parts of Thailand, actively go from city to city propagating eye donation. And you'll be surprised that some Muslim countries have even issued fatwas. Fatwa is a religious edict which has to be followed, calling for eye donation. So Egypt, Iran, some of the most the religious fanatical countries have issued fatwas calling for eye donation. A country which has got amongst the highest eye donations per capita is Iran. Highest donations per capita. Can you imagine a Muslim country like Iran? So no religion forbids eye donation. It is misinterpretation of religion which causes the problem. Is the procedure cumbersome, time consuming? Not at all. It's easy. Almost no paperwork is required. My neighbor died. What should I do? If antibiotic eye drops are available, you can put frequently. Others, no need to buy them. Call the nearest eye bank. If there is an air conditioner, leave it on. Otherwise, at 2 a.m. if patient dies, don't purchase an air conditioner. Switch off the fan if there is a fan in the room. Most important, call up the eye bank, give detailed address with immovable landmarks, or give a Google map so that they can find you without wasting time. When the eye bank team arrives, show the eye bank team the cause of death certificate, because the eye bank, we can only collect the eyeball from a dead person. Unlike in brain dead for organs, here the patient has to be completely dead. Even the brain should be dead. So the family physician or somebody has to certify that the patient is dead. We don't want legal problems afterwards. And the eye bank team will come with a form. You don't have to do anything. Any two relatives can sign. It can be third cousin from mother side and fourth cousin from father side. It doesn't have to be next of kin. Any two people should sign, so that we are, because sometimes what happens, an elderly person dies in, say, a suburb of Bombay called Kandivali. His one son is in New Zealand and one daughter is in Timbuktu. How do we get consent? So it doesn't matter if some nephew, niece is around, they can sign. There's no problem. No other paperwork is required. we ask the room to be cleared of all unnecessary people, because sometimes people faint when we are collecting the eyeball, and the eye bank team has to tend to the fainting person. We'd rather tend to the eyeball than fainting person. So we tell them, please leave. But if they want to stay in the room, they can stay while we collect. How long will it take? In Mumbai, the eye bank team reaches within an hour, and procedure is usually completed in 30 minutes. We collect a little bit of blood also, because we have to test for HIV/AIDS. And this is a patient in whom even the makeup is not removed. You can't tell that eyeballs have been removed, because we put cotton or we put a plastic eye inside and gently close the lids. So nobody can make out also that eyeballs have been removed. If you don't want to tell other relatives when you're taking for cremation, nobody will know. What about money? Any money is involved? No, neither the donor has to pay anything, neither the eye bank will pay anything. So there's no money involved. But the ultimate, somewhere we have to sponsor, because the eye banks have got trained technicians, eye bank managers. The medium in which we store the eyeballs costs money. The eye bank is 24/7 air conditioned. The eyeballs are stored at a very low temperature. So all these costs are there. So we ask the ultimate recipient to pay a small processing fee to the eye bank to cover the expenses. In Mumbai, 70% of the corneas are given to the municipal and government hospitals free of cost. Organizations like Rotary and others contribute and support the eye banks. So we are able to do this. And the eyeballs which are given to private practitioners like me, I get, if I am charging for the corneal transplant surgery, my patient will pay a small amount as processing fee to the eye bank. That's how the finances are. But no recipient is ever refused a cornea due to inability to pay. Even in private sector, most of us will do free for poor patients. So a little bit on what is meant by HCRP, or Hospital Cornea Retrieval Program. We try and collect eyeballs from people who died in hospital, because the quality of the corneas from these is much better than those who have died after prolonged illness at home. What about Rotary? If you're a Rotarian physician, I see a couple of doctors in the audience here. So promote with posters in your waiting room, so patients will ask you questions about the procedure. We have pamphlets prepared by the eye bank which you can distribute. And if you're keen to help, our eye bank staff can even train you, and technicians can also collect eyeballs. We can train your staff as well to collect the eyeballs. As an individual, as a Rotarian, you can talk to friends and sensitize them about eye donation and how easy it is. You can put up posters in your building society. I'll be happy to give you posters. And if a death occurs in your neighborhood, you can mention eye donation to the grieving relatives and offer to call the eye bank and arrange the whole thing. It just takes one phone call. As a Rotarian, you can organize a club visit to an eye bank. I'll be happy to arrange this for you. The eye bank in charge, we have managers in charge, will be happy to show you around, answer any questions. You can donate money to the eye bank. You can sponsor corneal transplants, can arrange for members to sign pledge cards. So many things that we can do as Rotarians. Let me now show you a few surgeries so this is a full thickness. Keratoplasty is another word for corneal transplant. So this is a full thickness cornea where the whole cornea is removed, because the surgeon, while putting in the lens implant during a cataract surgery, had caused a problem. So the cornea got damaged. So the instrument that you saw, that white instrument, was a corneal trephine. So we punctured the cornea with 8 millimeters in size. Now I'm cutting the cornea out. So the cornea is being excised. So this is the recipient cornea which is removed. The IOL, the lens implant, was damaged. So it is being cut and removed. Now remnants of the cornea are also in the iris. Some lens material was left behind. So that is being removed. The space is being made. The extra cataract material which is left behind is removed. This is a new lens which is being put in the eye. And now this is the donor cornea. See how clear and transparent it is, and this is stitched into place. So this is how a corneal transplant is done. So this is a keratoplasty, a fancy word for corneal transplant. With an IOL exchange, the intraocular lens was removed and a new lens was put in. This patient will see very well. Now this is DALK or the anterior lamellar keratoplasty. The front portion only is being operated. So the rest of the cornea was clear, but the cornea was very triangular in shape. The shape was bad. So he was seeing very poorly. So I have refined this, but I'm not removing the whole thickness. We are putting an air bubble inside to separate the front portion of the cornea from the back portion. I'm cutting only the front portion of the cornea, not the whole thickness. So the inner lining is still there. And what I'm removing is only the front portion. This is a more delicate surgery requiring more skill. So the front portion, so I've put that frothy bubbles that you could see so that I can cut and leave the bubbles there in the inner part of the cornea. So gently I'm removing only the front portion. It requires more skill and more time. This is called DALK or deep anterior lamellar keratoplasty. Anterior means front. Lamellar means only a portion. So this takes about 1 hour to do as opposed to about half an hour, 45 minutes for a full thickness corneal transplant. So you see these bubbles which are there. Bubbles are in the remaining part of the cornea which I have not removed. Now this is the patient's own cornea. I remove the inner lining and put only the top lining and I'm stitching it up. So this part is just like in a full thickness corneal transplant, but the inner lining is not used. Patient's own inner lining was used over here. And the stitching is the same. So this is a very safe surgery. And this is the opposite where only the inner lining is being used. So this is a little more tricky. This is an artificial anterior chamber. This is we hold the patients. This is the donated cornea. Donated cornea is held in a sort of clamp like this, and it is dissected out. The front portion is removed, and the inner portion is going to be transplanted. These are some markings made on the cornea, but we are going to remove only the inner lining. So this is an even more delicate surgery. We are entering the eye now we are scraping out the inner lining of the cornea. With that instrument, we are scraping out the inner lining. Now we are making an opening from the outside, and I'm going to push only an inner lining inside. So this is a little technical. We are making a small space. This is only the inner lining. See, the whole cornea is being held by me, but only the inner lining has been separated and is being pushed into the eye and put in. So this is only the inner lining which is transplanted. It's called DSEC. Now this is an artificial cornea. You mentioned in my biodata that I'm one of the few people who do artificial. Sometimes the cornea has got so many blood vessels. You see all these red marks that you can see, these red lines that you can see. These are all blood vessels. Now these blood vessels have grown on the cornea. Typically in a patient who has got chemical burns, tuna going into the eye or acid somebody has thrown in the eye. So the whole cornea is white and there are blood vessels. Now blood vessels, what happens? If blood vessels are there, then the body will come to know that there is a outsider which is come and it will attack and cause rejection. So we need to put an artificial, a plastic cornea. And this patient had glaucoma also. The pressure in the eye was high. So at the same time, I'm putting a valve to relieve the pressure. It's a little technical, but we'll enjoy the video. This is a patient who's 65 years old with a failed. So this is a glaucoma valve. This glaucoma means raised pressure. So I'm putting a valve inside the eye through which the water from the eye will continuously drain out. Identifying the superior and lateral rectus muscles. Then I'm removing the cornea. in the central portion.
Cornea is now refined out. This is an 8.5 millimeter trephination.
I'm using the patient's own cornea to cover the tube which was there.
Lower surface support to remove, and this trauma is further delayed in the
So
future.
I've put that, I've closed that tube. I've closed, put the tube inside the eye, and then I'm proceeding with putting.
Now a 9 millimeter.
So this is the artificial cornea, which is a hole has been made in the actual cornea. This is the old lens of the eye which has been removed. We don't need the lens. This is the artificial cornea which is in the center. See this, and this is the patient's the donor cornea which is being stitched just like you saw. But this central hole, this is the plastic cylinder which I put in. So this cornea which is there, the eye bank cornea supports this plastic cylinder. He is seeing through the plastic cylinder. This human cornea will become opaque with time, but this plastic will remain open and clear, and that is how you will see. This is called keratoprosthesis or artificial cornea. Thank you so much for your attention. I'll be delighted to answer questions. I apologize if I have exceeded time a little bit. Lal, over to you.
Thank you very much, Dr. Maskati, for giving such an elaborate presentation. And as I know that you are one of the very busy doctors, so thank you for joining on a very short notice also, I must say. My question before I will open to the house is, what about the xenotransplantation? Are we also doing research for the eye for the xenotransplantation?
They are doing, the research is going on, but the research is still not, because they're using pig corneas. The problem with pig corneas is the rejection rate is high. Just like a pig heart also, they're having problems. So they're trying to use some novel techniques. More than that, now, you know, this is the age of 3D printing. They're trying to 3D print human corneas, which is very fascinating research. And I'm expecting as close as 5 years from now, we will have 3D printed corneas available to us, which will not get rejected. So the need for human corneas may go down, but at least for the next 5 to 10 years, we in Rotary must continue to promote organ donation and eye donation. Thanks, Lal.
Thank you very much, Dr. Maskati. Now I'm opening this for our members. Please unmute whosoever wants to ask question or raise the hand so that I can immediately. Yeah, I can see Rotarian PHF Dr. Rohan S. Monis has a question. Yes, please.
Dr. Maskati, good evening.
Good evening.
Thank you, sir, for your very profound presentation. It was in-depth. Sir, with respect to organ transplant and tissue transplant, I believe if you want to do tissue transplants, the Organ Transplantation Act doesn't hold strong there. So you can actually pull out the corneas, not in a hospital setting, even out of hospital settings.
Absolutely. Absolutely. Yeah. Yeah. There is a section in TOTA, in the Human Organ Transplant Act, which deals exclusively with the cornea. So there is, so the rules are much less rigid here.
So when you work in a
you
team,
don't need 2 opinions about death. You don't need 2 opinions because it's not brain death. It's complete death. So we don't need just a family physician can certify death. That is sufficient. It can be done in a home setting. It can be done by non-doctors. That is the beauty. We got, after a struggle of decades, we got Parliament to finally pass this rule because it was only doctors. And what happens is that if it was only doctors could collect, the family physicians were so busy. As you know, we have such few family physicians. To go to somebody's home in a slum and collect with no financial rewards, it was extremely difficult for them to leave busy practices. Every family physician is busier than he would like to be. So we got the permission to have trained technicians remove. So my eye bank trains technicians. So a 12th standard pass person can be trained and get a certificate from me that he is trained to remove the cornea. So he can go to the slum or jhopdi or wherever and remove the cornea. So that is a huge victory we got after decades of struggle with Parliament.
Thank you.
Thank you, Dr. Monis. Recently, Dr. Maskati, there was some news that Noto has taken a strong view about the eye banks, and this is that so many eye banks are running illegally. So what is the why they are insisting when you are saying that they are not so much strict about
No,
eye?
I'll tell you, it's not illegal. See, what happens is that there is something different. There is something called eye collection center and there is something called eye bank. So the eye bank is one which collects the eyeballs and stores them in special medium, processes it and grades it. We have trained technicians who say that the cornea is of excellent quality, good quality, fair quality, and it splits the cornea into layers and sends it to the doctor. An eye collection center is just a team of volunteers which goes to somebody's house and collects the cornea and sends it to the eye bank. So what is happening is, unfortunately, many of the eye banks were just glorified eye collection centers and many of them were non-functional. So there was a lot of, just like anywhere, charity money going down the drain and some mischief, much less than with organs. But and we are very happy that Noto is coming out with guidelines, and we also, because I'm part of the Eye Bank Association of India, we are on our own. We are also pushing Noto and working together with Noto for this.
Okay, thank you very much. I can see Dr. Kamal Jain. Is he there? He has raised the hand.
Yes,
Yes,
Kamal is here.
Yes, Rotarian Dr. Kamal Jain.
Good evening, sir.
Hi, Kamal.
Sir, are there any new advancements that can bring hope to the patients with irreversible blindness?
With which blindness?
Irreversible.
No, what is irreversible today may not be irreversible tomorrow. New technologies are coming in. But there is a lot of hype on stem cells. So let me first clear the air. Stem cells are used by us for transplant, but that is only for those in whom the corneal stem cells are lacking. In bad chemical burns and others, there we transplant stem cells. Stem cells themselves are not corneal transplants. And if the eye nerve is damaged or retina is damaged, as of now, the retinal transplants and other things are not possible. There is a lot of research going on, artificial retina and other things. Retina is the film at the back of the eye. For those of us who are above 50 and remember film cameras, the film at the back of the eye is like the film in the film cameras. Those who are youngsters and 25 plus will not know because they only take pictures with mobile phones. So the film at the back has got 2 million cells. Each cell from that retina is connected to a fiber like our TV cable that is called the optic nerve, which goes to the back of the brain. So if the nerve or the retina is damaged, as of now, you can't do anything. But we are trying to have artificial cornea, artificial retina chips put in. This is expensive. At the moment, it costs about $5 million each, and it is being done as research in universities. It's not in open for the general public as yet. A lot of WhatsApp come in, but they're all at the moment all rubbish. Thank you.
And we also are they're also working on gene editing.
Yes, that's another interesting field where we are working, but at the moment there's still a long way before clinical applications.
And sir, what about whole eyeball transplant?
Whole eyeball transplant is not possible because the optic nerve contains 2 million fibers because the retina has 2 million cells. So how to connect the whole eyeball, the retina, keep it alive and connect to 2 million? Imagine stitching one retinal cell to one fiber. It's not possible. So as of now, it's not possible.
They are working on ECMO machine.
Yes, like there is some Korean work, South Korea, they're working on it, but these are all sensational news which comes on WhatsApp and dies away after 15 days. So till we start seeing results, these are all premature.
Thank you, sir.
Thank you very much, Dr. Jain. Any other question anyone wants to ask? Please raise your hands or unmute yourself. Yes, Dr. Moniz again wants to ask. Yes, please unmute. Please unmute, Dr. Moniz.
I'm sorry. So when you said you harvest stem cells, is it from the patient himself?
There are two types. Suppose there is one eye with chemical injury, other eye is normal. Then we can harvest stem cells because the other eye has got enough stem cells. We can harvest about, these stem cells are around the cornea. You see the black portion that you see, all around that is a layer of stem cells. So we can harvest about 1 to 2 clock hours. If you count that as 12 clock hours, 1 to 2 clock hours of stem cells from the opposite eye, other eye can be harvested and grown either in the lab outside, or it can be grown in the eye itself. So that is, if it's unilateral blindness, stem cell loss, we can take from the other eye. If it is both eye stem cell loss, then we have to take from a relative or somebody like that. And then it's just like your kidney and liver. We have to suppress the body's immunity because the body will attack it as an outsider. So we have to use a lot of immunosuppression, and the results are also not so great. Thanks, Ron.
Thank you, sir.
One more question from my side. How many days or years this eye cornea can be stored? Like in skin, it can go up to 5 years in skin bank.
As of now, with simple, inexpensive methods, we can store up to 15 days. Since the demand is so great, usually within 2 to 3 days it is used, because even if my patient comes from northernmost corner of Mumbai and of India and has to be operated in southernmost corner of India because his eye surgeon he loves is there, in 4 to 5 days he can easily make the trip. So up to 15 days it can be stored, but we have the technology to store for up to 1 month. But that storage for up to 1 month to even to 2 months is quite expensive, and we never need to do it because the demand is so much more than the supply.
Okay. I can see Rotarian Rupa Arora's hand. Are you there, Rotarian Rupa Arora?
Yes, Rupa is there. Yeah.
So switch on your video, please, and unmute yourself, Rotarian Rupa Arora.
Rupa Arora.
Yeah. Yes.
Yes. Hello, good evening, sir.
Hello, good evening, Rupa.
Good evening, Rupa. डॉक्टर साहब, आपका जो आज का सेशन था बहुत ही इंफॉर्मेटिव था, बहुत ही अच्छे तरह से आपने समझाया। रिसेंटली मेरी मदर इन लॉ का कॉर्निया ट्रांसप्लांट हुआ है, तो उनको जॉगरन सिंड्रोम है, जिसकी वजह से उनको ड्राइनेस बहुत रहती है।
तो जोगरेन सिंड्रोम में कॉर्नियल ट्रांसप्लांट यूजुअली काम नहीं करता है, बिकॉज हमें नॉर्मल टीयर्स की जरूरत होती है। जोगरेन सिंड्रोम में हम अगर कॉर्निया ट्रांसप्लांट फेल होवे तो हम आर्टिफिशियल कॉर्निया करते हैं, क्योंकि उसमें टीयर्स की इतनी जरूरत नहीं होती है। तो अगर ये सक्सेसफुल हुआ तो ठीक है, नहीं तो फिर आर्टिफिशियल कॉर्निया कर सकते हैं।
ये सर 3 to 4 टाइम्स उनका हो चुका है।
मैं वही बोल रहा हूँ कि उसमें सक्सेस के चांसेस कम है, बिकॉज टीयर्स कम है।
उनको हर बार फंगल इन्फेक्शन या कोई ना कोई इन्फेक्शन बहुत जल्दी हो जाती है।
बिकॉज अपने आंख के कॉर्निया को प्रोटेक्ट करने के लिए अपने आंसू जो है वो बहुत इंपॉर्टेंट है, और शोगरेन सिंड्रोम में वो आंसू बनते नहीं है, तो वो प्रोटेक्शन नहीं मिल रहा है। इसके लिए बार बार इन्फेक्शन होता है, कॉर्निया खराब हो सकता है।
नहीं, पर रूपा जी आप कह रही हैं कि आर्टिफिशियल लगा है उनको कॉर्निया?
नहीं, उनको रियल नेचुरल कॉर्निया लगा है।
नहीं, वो कह रही हैं, सॉरी। हाँ, रूपा जी बोलिए।
सर उनका 3 से 4 बार कॉर्निया ट्रांसप्लांट हो चुका है, एक बार उनका आर्टिफिशियल कॉर्निया ट्रांसप्लांट भी हुआ है।
नहीं, बट वो भी अलग होता है, अलग-अलग
वो भी उनको इन्फेक्शन हो गई थी, जिससे थोड़ी देर बाद उनको दिखना बंद हो गया था फिर।
हाँ जी, वो हो सकता है। नथिंग इज 100% इन मेडिसिन।
चलो, मतलब इतनी एज हो चुकी है, अभी भी वो तैयार रहते कि किसी ना किसी तरीके मुझे थोड़ा बहुत दिख सके, तो मतलब 80 इयर्स होने के बावजूद भी उन्होंने ये इस बार ट्रांसप्लांट करवाया। अब होपफुली वो हमें लगता है कि शायद ये इस बार सक्सेसफुल रहे, क्योंकि हम सारे प्रिकॉशंस जो हैं
very good
we are using.
And I will tell you, Dr. Maskati, Rotarian Rupa Arora is a kidney donor herself.
Wonderful.
And she has donated to her husband. Liver donor.
Liver, wonderful.
She has donated to her husband.
Wonderful.
And she is from Chandigarh. Okay. I can see Rotarian Sudhir Saran. Yes, please, go ahead.
Sudhir ji, kahiye.
Very illuminating presentation, Dr. Maskati. Technology is advancing quite low and quite fast. And what is happening is your eye surgery is very, very precise degree of that one. Is there a scope for robotic surgery in your field?
Yes. They are developing. You see what happens, as you said, the movements are very fine in the eye. They are not able to make robots to make such fine movements, but progress is there. We feel in 4 to 5 years, a robot will be better than I am. But as of now, for corneal surgery, we are not using robots. Yeah.
Thank you.
Thank you very much, Professor Saran, Rotarian Professor Dr. Saran. Anyone else wants to ask question, please raise your hand or unmute. Rotarian Ramnath Pradeep, your question, please. Please unmute. Please unmute. Yes, please.
Dr. Maskati, your presentation has been one of the very excellent one, and everybody knows in the Mumbai Rotary, entire Rotary Club knows your skill and your passion for the eye donations and eye transplantation. It's a very wonderful presentation you have made. I really appreciate, and I once again I have gone. I had a chance to meet you in Sefi Hospital with Dr. Chunia.
Yes, yes.
So it's really a very wonderful presentation, and you have been doing quite supporting to the Rotary Club also. So thank you very much for your passion, and thank you for your passion for particularly to the poor people who are cannot afford. You are doing a free of cost. That is what we have been hearing a lot about, not only in Mumbai but outside Mumbai also.
Okay, thank you very much.
Thank you.
Thank you, Rotarian Ramnath Pradeep. Dr. Maskati, like for organ donation, now the government of India has come out with lots of scheme where the BPL or the poor patients can got up to 15 lakhs of rupees for the transplant. And now recently, the Maharashtra government, about 4 or 5 days back, they have signed an GR, the Chief Minister, where they have clubbed the PM Ayushman Bharat PMJY scheme with the Jyoti Phule scheme of Maharashtra. And they have done for like liver, they have raised the limit to 22 lakhs for this. About eye transplant, how much it costs, whether it is covered under any of such scheme for the BPL or the poor patients, or it is only just charity by Rotary or by Dr. Maskati?
No, I'll explain the economics. See, what happens is that, as I said, 70% of corneal transplants are done in government and municipal hospital like JJ Hospital, KEM, Sion, Nair, other municipal hospitals. So there the patients get it done free of charge completely. Even our eye bank gives the corneas free of charge to them. So 70% of the patients are covered. Those who come to us in private practice, most of us, in private practice for affording patients, the average cost for a corneal transplant is approximately 1.5 times that of a cataract surgery with a monofocal simple lens implant. Whatever the surgeon is charging for that, if the surgeon is charging, say, 30,000 rupees for a cataract surgery, he will charge 45,000. If he's charging 1 lakh for a cataract surgery, he will charge 1.5 lakhs. So roughly it's about 1.5 times what a surgeon will charge for those who are affording and come to us in private practice, because the amount of training, years of training to become a corneal surgeon, the equipment, all that costs money. So, but no eye surgeon, even in private practice, refuses a corneal surgery for failure to pay. So most of us not only do, we of course charge our affording patients, but we will happily subsidize. We use that money to subsidize the patients who cannot afford. So yes, it is covered by PMJ and all the government schemes covers it. But even hospitals in private practice which don't take this PMJ and others are happy to do so. Usually there is no problem of finance as far as this is concerned.
Thank you very much, Dr. Maskati.
Can I ask one more question?
Yeah, please go ahead.
Yes.
Okay. This is a kind of science fiction class of question, Dr. Maskati.
Yes.
Forgive me for that question. Listening to you, it inspired me to ask this question. Last few years, there is a Nobel Prize given for discovering the genes which sense the pressure and the temperature. Those genes have been identified in the scientific world.
Yes.
Now, the question goes like this: if I put a connector to your brain as an eye surgeon specialist and train my robo to identify the pressure when we are doing the actual operations, do you see a future when you can train a robot to your level of finesse, when it can separate the sophisticated corneal operations?
Everything is possible, because I've been looking at the research very keenly, and there's a lot of developments in skill. We just hope that it doesn't happen in my lifetime and I'm not replaced. But yes, it is entirely possible that we will have robot. The robot will be controlled by a human being. It has to be controlled by the eye. So the eye surgeon has to be skilled. You cannot tell the robot, please do it, and then go and play rummy outside. That's not going to be possible. The eye surgeon has to be there, and he has to micro control the thing. But I think it will be much more precise than a human hand in the next 5 years.
You will not be replaced, because in the whole system of things,
No, I'm joking. I will not be, because I will be needed to direct that robot.
Yes, you will be required very much on continuing basis for training as your skill advances.
True.
And so the benefit will happen is, in your hospital, instead of being just one Dr. Quresh Maskati, there'll be more than one available there.
Let us hope so. Let us hope your dream comes true.
Thank you.
Thank you.
Yes, Dr. Moniz.
Yes, sir. So you said that your team comprises of 12 pass outs, grade 12 pass outs. And so what is the turnaround time to get these boys and girls trained so they can go and harvest the cornea, sir?
It depends on how skilled they are and how much time they devote. We even take those who are working part-time in jobs and train them part-time. So anywhere from 3 to 6 months, they have to visit our eye bank, not on a daily basis. Some of them come once a week, twice a week. We give them theory talks. We bring the whole eyeball from a donor, which cannot be used for this is the research. So we train them on how to cut the cornea out, how to put it in the bottle. So all this, it average 3 to 6 months. If somebody is coming daily, we get some patients, some technicians who come from Africa and other countries for training. So we train them in about 15 days, because they are whole time with us. So if they're whole time with us, about 15 days, we train them and we give them a certificate that they are trained, and that is valid in India at least. But if they are from within Mumbai's city, then it averages 3 to 6 months. Most of these people come part-time, an hour, once a week, twice a week, like that.
And how much you are charging for that?
We don't charge. We don't charge.
So, and these students have to invest in their own instruments so that they can harvest?
No, sir. We give them everything. We give them everything. We give them help. We have that's where Rotary comes in. Rotary sponsors this training. Yeah.
Because Dr. Moniz is an administrative officer of a medical college in Mangalore, Karnataka.
Right.
And they have started the
we have trained several technicians from other eye banks across the country. They have come here, taken training, and gone back to their own eye banks. So we are happy to provide training, sir, to anybody.
Dr. Moniz, you have not started the eye bank in your hospital, or is it there?
No, sir. We have not started. The first batch of postgraduates just joined last year. So the plan is to take it forward. Yes, this is going to be a very strong lead for us, sir.
We will, Dr. Moniz, give you whatever guidance, even to set up the eye bank. We have the whole SOP in place. We'll be happy to share it with you, no cost.
How much it costs to set up an eye bank, Dr. Maskati?
It depends on the amount of marble and granite you use. But
otherwise, for the machinery and plant and machinery.
But otherwise, in about 50 lakhs, you can get a decent eye bank. Yeah.
But you require 50 lakhs for
because some of the we have a machines called a specular microscope, which costs about 20 lakhs to study the. We have to grade the cornea into excellent grade, and so we have to see the inner lining. If the inner lining is good, then it can be used for inner lining transplant. If it is not good, we give it for outer lining transplant. So some of those machines cost about 20 lakhs, some are 10, 15 lakhs, like that. So the machinery itself would be about 50 lakhs.
Okay. Thank you very much. I think the questions are over. So over to you, Inspire Secretary Rotarian Ruby Agrawal.
Thank you. Thank you so much, Dr. Quresh Maskati. It was a very, very informative and enlightening session. And we have a lot of chat box, beautiful comments for you from our members who are on mute. and wonderful presentation, informative, very informative. Thank you. Fantastic presentation. Thank you for the information, etc. I request Rotarian PHF, Dr. Rohan Monis, to please give the vote of thanks.
So good evening, everybody. This was a very beautiful, insightful, and a very like a hands-on session, because pictographically, I think Dr. Quresh has done amazing justice, and he is leading by example. I mean, because the previous time I've heard like the Arvind story, sir, wherein they have students, young as grade 10ers, 11 graders coming in and getting them sorted out, and the story went very strong. And this is the next time I'm hearing that how healthcare, and especially for eye donation or corneal transplants, is going to be a very like a disruptive change. Thank you, sir, for your time. Amazing thing, amazing stories, amazing experience shared with us on this amazing platform. And I would love to connect with you, sir, personally. And from the entire team of Rotary Club of Organ Donation International, I wish you an amazing week. And thank you, all of you, for your time and presence. See you soon.
Thank you so much. Over to you, President.
Thank you very much for your presentation, Ms. Dr. Quresh Maskati. It was a very, very enlightening presentation, and I thereby